So it's an honor and privilege for us to welcome Dr. Michael Schubert, who's with the Johns Hopkins University School of Medicine in the Laboratory of Vestibular Neuroadaptation and in the Department of Otolaryngology, Head and Neck Surgery, and Physical Medicine and Rehabilitation. He's going to be speaking to us today on the principles of vestibular-ocular reflex adaptations in humans. So very interesting topic and an expert in the field. So we look forward to, Michael, to hearing your talk. Thanks so much for joining us.
Thank you, Bill. It's an honor to be talking here. You're kidding me at the House Institute. I'm very excited to be here, and I thank Dr. Bigelow for the opportunity. And I will disclose that this technology that we developed has now been licensed. That's pretty exciting. However, the company, the startup company, Equilibrium there, has not funded any of the work that's going to be presented. And frankly, they've got a long way to go before I think we see any of this stuff out on the market, but I do want to disclose that. Also, the collaborators. This has been my first NIH award was in 2005, right as I had transitioned out of my postdoctoral fellowship into faculty. And that grant was based on this method. So this has been going on a long time. And largely the laboratory of Americo Miliaccio, who's a biomedical engineer that studied with Michael Hamalgi in Sydney, who did a postdoctoral fellowship at the same time in Lloyd Minor's lab. So we were in Lloyd's lab together, and Charlie Del Santina and John Kerr, we were all kind of in that lab together before Lloyd jumped to become the chairman of the department at Baltimore. And Americo took this idea that I had gotten a grant with and basically turned it into a device that I'll show you a picture of that we have built for people to take home. The take-home message is that there are clinical practice guidelines for the rehabilitation management of vestibular hypofunction. That is, there's enough data to support that physical therapy for those with vestibular, peripheral vestibular end organ damage will benefit. And part of those exercises mandate these people should be doing gaze stability exercises. We'll talk a little bit about what those are. But these current gaze stability exercises really don't seem to change the vestibular-ocular reflex. This rehab helps people. Their balance gets better. They feel better subjectively, but it doesn't really change the gain, the magnitude of the strength of the reflex. Something else to consider is that when we see folks with unilateral vestibular hypofunction, the contralesional side often is impaired. I'll show you an example of that. Sometimes as much as 20 or 30% reduced on that unaffected side as well. Patients with bilateral vestibular hypofunction can adapt their vestibular-ocular reflex, although we believe, and we've shown some evidence for this, that they have to have some residual function. If their VOR is completely absent, they don't seem to do as well with the vestibular-ocular reflex training. The brain can tolerate opposing yet simultaneous training. I'll show you what that looks like. That's pretty neat. And the unique vergence effect on the VOR may be useful for gaze stability. We found out that providing a target that's of sharp contrast is important. And then finally, head impulses should be incorporated for training. So we're going to talk about the vestibular-ocular reflex. You're all experts in the ear and the inner ear. We'll review that literature briefly and then talk about kind of what's new and how we've tried to translate from our lab into the clinic for physical therapy or other providers that might be treating these patients with rehabilitation. So here's an animation that should be playing, showing you the vestibular-ocular reflex. We've got a green excitatory labyrinth here on the left and a red inhibitory labyrinth, so to speak, on the right. And of course, we have the shortest reflex in the body, the vestibular-ocular reflex, which is responsible for keeping the eyes still during a head rotation by counter-rotating the eyes in the opposite direction of the head. And it does that with an exquisite precision, about 6 to 10 milliseconds, depending on what article you read and what animal model's been studied. And that's just showing the relative excitatory and inhibitory contributions. Now, The vestibular system also sends signals down to the spinal musculature in the limbs for gait and postural stability. But as those synapses leave the brainstem and they start to travel south, it gets complicated and it's harder to map that. And so the VOR has been a great model for motor learning for many, many years. And that's what we're going to focus on. Turn off this volume. This is a mock-up of what patients with vestibular-ocular reflex pathology report. Not all of them report this. This, of course, is oscillopsia, which is this perception that the world is moving, typically during head movement. Of course, people can have oscillopsia when they're still, if they have a spontaneous nystagmus. But this is really a vestibular, sort of a vestibular unique phenomena where the eyes are not stable during head movement. And we mock this up by putting cameras on our dashboard or walking with our phone, and just to show what gaze instability looks like. And I'm sure you're all very familiar with this. This is the classic clinical head impulse sign for an abnormal vestibular-ocular reflex. We see with a passive head rotation towards the right, there's a corrective saccade right there. The eyes do not stay focused on the target during the head rotation, and the brain is forced to then reacquire the target. So clinically, we say, hey, keep your eyes on my nose. I'm going to move your head quickly. And then we do this test to see if their vestibular-ocular reflex is working. We can measure that. And we'll talk about this particular slide later. But I just wanted to show that the red eye velocity here is abnormal, and then after some training, it's normalized. So these patients will report, the world blurs when I move my head and when I'm walking or if I'm turning a direction, and that's one of the symptoms. This is how we measure the vestibular-ocular reflex now. I know this is a little bit small, but you can appreciate that the subject is wearing these video oculography goggles. This is the odometrics, or now the NATIS video head impulse test system. And we just do very small amplitude head rotations, and we measure both eye and head velocity. And when we do that, we get plots that look like this. This is a plot, this normal plot on the top of your screen is the head and eye velocity. The eye velocity has been inverted, so you can quickly compare the purple area to what's really difficult to see, which is kind of this pink area. That's because the vestibular-ocular reflex is good. The eyes are moving at relatively the same velocity. The gain, which is up here, is 0.99. That means that the eye and head are almost perfect. VOR gain is defined as eye velocity divided by head velocity. So if I turn your head 100 degrees per second to the right, your eyes should move to the left at that same 100. If they move less than 80, there's an abnormality. And that's a rough guideline that gains that are abnormal are below 0.8. And that's what this lower plot is showing. It's not terrible. It's just borderline abnormal, but it is abnormal. It's 0.78 here. It's a little hard to see. But if you look at the raw plot, you can see that the purple area underneath the eye velocity curve does not match, does not fill in the red head velocity area under the curve. And then there's the saccade, there's the sharp peak, after the head velocity that's generated to try to get the eyes where they should be. So these corrective saccades are a strategy. They're a recruitment strategy by the brain to keep the eyes where they should be. And we believe that they are useful and probably have a rehab purpose. And one thing that we don't yet consider that's been born out of the animal models is that there's a difference if we measure the vestibular-ocular reflex between acceleration and velocity. So I won't spend a lot of time on this, but there's one other slide to show you. So this is a step acceleration in a monkey. This would be equivalent to a rotary chair test, where we sit the person in the chair, we accelerate them at some magnitude, and then they settle out to a constant velocity. So here the constant velocity gain is 0.98, but the acceleration gain is above 1. That is, the eyes are actually moving a little faster than the head. And the point is that there are these two gains depending on how we're moving. And we're not savvy enough yet in clinic to know how to deal with this in people, but it probably is important for rehab. And that's illustrated here. So Rick Clendaniel, when I was a postdoc, was in Lloyd's lab. He's a physical therapist. He's moved on to Duke. And he did this study, and it illustrates this point. So it's a kind of a busy slide, but here's the point. Right here, the middle slide and this slide on the end. These monkeys have been giving magnifying glasses that make the world look bigger than their brain is used to seeing. And when we put magnifying lenses over monkeys or people, and the brain sees images that are larger than it expects, it increases the magnitude of the vestibulo-ocular reflex. So if the magnitude of the vestibulo-ocular reflex is adapted up, then we should see gain values that are 2.2 when we increase the size of the world. Similarly, when we put animals, put lenses on animals that reduce the images of the world that the brain is relatively used to, then the gain can be driven down. And if the gain is driven down, ideally, we should see gain values of 0.45. We generally don't see that we can drive up to perfection what our training stimulus is. Nonetheless, look at the difference when we measure gain after these animals have worn these magnifying lenses that make everything big, 2.2 times larger than normal. The gain for acceleration is nearly complete, 2.0. It should be 2.2. And you can see the eye velocity here in this first blue arrow is faster. It's exceeding the head velocity or acceleration. But the constant velocity gain, although it increases, it's above 1.3. This line is higher than where the chair or the head rotation is. It's not near 2. So again, to illustrate that point, when we magnify, we get a little bit closer. It's easier to actually reduce the gain than it is to increase. So this is how we've studied VOR adaptation for basically 80 to 100 years now. This is an illustration of retinal slip. So this is an animal who's used to seeing the world object here, a banana, at a certain size. We move the head one direction, the eyes move in the opposite direction. That's the vestibulo-ocular reflex. There's no slip on the retina. If, however, we put magnifying lenses over that animal, we make the world, in this case, the banana, look larger, they make a head rotation and an equivalent eye rotation that's not enough to keep the target stable. So it slips. The target moves on the fovea of the retina a little bit. And after time, that motion on the retina stimulates a greater eye velocity. So now the head moves the same amount, but the eye has been trained to increase its movement or velocity. And so there's no retinal slip, and that requires a gain change. So retinal slip is the most powerful error signal that we know of to drive change of the VOR. And that's what we're trying to do in our research in our lab, is to come up with ways to induce retinal slip that change the VOR. And that's what we're going to talk about related to the work that we're doing. The literature has shown that if we do these retinal slip studies for minutes to hours, we can change the gain somewhere between 10 to 35%. There are some famous stories that most of you probably are familiar with. Stories, there's studies where we have researchers have induced gain change for hours to days and induced very significant changes. In fact, one famous study by Melville Jones reversed the vestibulo-ocular reflex completely, which means subjects had to wear glasses that reversed the visual world. So when people turned their head to the right, the world moved to the right. Now, those people had to be walked by hand through the environment because it was too dangerous otherwise. So obviously not practical, but proved that the gain can really be modified. And there's some interesting studies that have been borne out of the animal models that suggest if you train the gain to be low, to bring an animal in and reduce the VOR gain through motor learning, it takes a long time for that to recover spontaneously. However, you bring that same animal in and you increase the gain. You give them a signal that's going to increase the eye velocity. It decays very quickly back to baseline. So we kind of have that. We have to work. That's not in our favor. We want to increase the VOR gain in lesion individuals. So a couple other points. This was some of the early work to show that the vestibulo-ocular reflex adaptation occurs at the unique frequency that you train. So really busy slide. I'll just point out the highlights here, which is this gain ratio along the y-axis here is the amount of adaptation change that they meant. So these are goggles that they've put over animals where they've tried to change the gain to 1.5 goggles or 0.5. And then they tested them at this frequency. They spun them at 0.5 hertz when they wore 1.5 goggles. They spun them, so to speak, at 2 hertz, 5 hertz, 8 hertz, 10 hertz, while wearing either magnifying lenses or minimizing lenses. And what you see is the peak, the greatest amount of gain change occurs at the training frequency. So when we train at 0.5, we see that the frequency peak is here at these low frequencies. When we train at 2 hertz, we see the peak of the learning happens at 2. Train at 5, the peak is somewhere around 5. It kind of washes out a little bit at these higher frequencies. But that was context specificity. And context specificity simply means that the motor learning occurs best in the vestibulo-ocular reflex at the training condition. These are 3 different studies, all illustrating the same point, and we won't spend time on them except this one down here. These were squirrel monkeys that we put minimizing lenses, so we're going to drive the gain down, and we trained them when their left ear was down. So they came in, put them on left side down. They looked at, they were rotated at a sum of sines, so multiple frequencies, while they were wearing these glasses that made things look small. And we did that for about 3 hours. And then we measured their VOR gain in left ear down, the training condition, in right ear down, and in upright. And then we put them back into their home, and we brought them back the next day. Post-adaptation day 1, measured them, same 3 positions, put them back home, brought them back the next day, post-adaptation day 2, etc. And what we found is that there's retention, that when they're measured in the training position, left ear down, the amount of change, it does start to recover, but very slowly it stays down. And even after day 7, it was significantly still reduced compared to their pre. The other conditions, right ear down and upright, recovered, at least at that day 7. So again, just illustrating that there's this unique sort of context specificity, and that has rehabilitation implications. First study, Gary Page, showing that in patient subjects, we can change the VOR gain. So these are VOR gain being driven up. So these are humans wearing lenses that magnify the world. They are being rotated at 0.25 hertz. So there's sinusoidal, very slow. And what it shows is younger healthy, older healthy, and patient subjects. And all of them have VOR gain change, some upwards of 65%. And then as we increase the velocity that we measured, it tends to go down. But again, an important early study to say, we can change the VOR gain when it's pathologically low. So that was a very quick summary of the traditional VOR adaptation. And all of those studies were done in complete dark, right? They tend to, overwhelming majority were done with whole body rotation. Some of them were done while walking around and having people with them because they would bang into walls and would hurt themselves without guidance or somebody, protecting them. They tend to be low frequencies of head or whole body rotation or low velocities of head movement, tends to be sinusoidal. And none of that stuff that they've measured, and although it's exceptionally useful for establishing, scientific principles, they're just not practical. They're not specific to how we live in the real world. They're not very functional. So one of the things that our lab wanted to do was try to get this information into practicality. And so before we talk about that, I just wanted to mention a little bit, going back to what we mentioned earlier, which is there are these clinical practice guidelines in rehab for gait stability training. Gait stability exercises, right now, when you refer your patients to vestibular rehabilitation, the physical therapist, perhaps the occupational therapist, will tell them to look at letters while they move their head. And that's what these guidelines are suggesting they do. So if it's an acute vestibular hypofunction, we do that 3 times a day for 12 minutes total. If it's chronic, 3 to 5 for 20, bilateral, et cetera. And that's based on a lot of opinion, unfortunately. There is some evidence, and the evidence is not based on randomized clinical trial rigor yet, although that's starting to happen. So those exercises, however, don't seem to change the VOR gain. So here on the left side of your screen is a video head impulse test showing green head velocity and inverted blue eye velocity. And we can see that the blue eye velocity does not match the green. The strength of the reflex is very weak. It's 0.2, roughly 0.19. Remember, 0.8 or above is normal. After 6 months of doing this exercise, where a subject was looking at a laser target that did not move, but turned their head for 15 minutes while looking at that target, there's no change in the reflex. It goes from 0.19 to 0.21. It looks like the saccades change a little bit. It looks like they're firing more at the same time, but no VOR gain change. This is somebody with a vestibular hypofunction due to a vestibular neuritis. Over here on the right half of your screen, we did a similar study in folks after unilateral vestibular deafferentation from vestibular schwannoma resection. And the VOR gain change similarly does not move anywhere. This is passive video head impulse test, passive video head impulse test gain. Afterwards, there's no difference. Both of these papers have been published. So we've shown, as others have, that the vestibular reflex does not change to rehab. Now, again, rehab still helps, and it's the current standard of care, and it should be given, and we believe it should be provided to all folks that have a nerve hypofunction. Not everybody will need a very long or intense rehab effort, but it doesn't change gain. So we developed a method that we're calling incremental VOR adaptation, and I'll show you a video of how it works. But essentially, it's impulse training. Individuals wear a laser-mounted device on their head that detects head velocity and moves the laser target at a fraction of the head velocity, but in the opposite direction. So we train people to do impulses at these particular movement characteristics. So they're brief or small, and they're supposed to keep their eyes on the target. And as they move their head, the target gradually increases in velocity over 15 minutes. So this is an accelerated video showing that. So we're showing leftward head impulses. The laser target, every 90 seconds, so the epochs are 90 seconds long, gradually moves further and further, or faster and faster on the wall. So you can see it's increasing the retinal slip demand. The demand of the VOR is being asked to increase. And we can adjust this laser target to move at any VOR gain demand. We can start at 1 and go up to 2. We can start at 0.2 and go up to 1.2, et cetera. So that's the method that we have developed to see if we can change the VOR gain after 15 minutes of training in people. And that's what we're going to spend the next few moments talking about. This is another busy slide, but our first study showing that we can change the VOR gain in people using this method. And I'll just briefly point out that these are healthy control subjects up top. And so their gains start right about 1.0. VOR gain is on the left side here. And you can see, depending on the training, we had 2 different training paradigms, that the VOR gain goes up almost instantly. Each symbol, regardless of a red or black, is a 90-second VOR gain after 90 seconds of training. So you can see there's this gradual increase in VOR gain. These are the patient subjects. And we can see that most of them start off at a VOR gain lower. Now, this is an active head rotation. So remember, this is a training paradigm. They are actively turning their heads. So the vestibular system and the brain can augment the gain when the subject makes an active head turn. And so again, in unilateral vestibular hypofunction, we see that we can drive the gain up. This was really exciting for us to show, look, we can train the gain up during head impulses in 15 minutes. What we found was that after we stopped the training, though, only those that had used this incremental laser method had retention. And that's what's illustrated here. So these are the 5 patient subjects. This was a sort of proof of principle paper. We published this in 2008. And what you're seeing here in the clear columns are the individuals and the amount of gain change they had after the 15 minutes of training. And then the summary, the mean of all of that, versus their equivalent training with a different method, which basically was replicating what the clinic does. So the gray is the clinical method, and the clear is this laser method. And you can see that only in those that did the laser training was there's retention of the VOR gain by about 20%. Now, in the healthy controls, which is down here, you see that there is VOR gain change during both. And there's a little bit in the healthy controls, there was a little bit of retention. Turns out that these were significantly different. That is, the red or the laser was better, but in healthy controls, it's different. They've got a functioning system. So that was exciting, but we weren't smart back then to think that we should apply this to one side only. So that's what this is illustrating here. So this is the same figure that I showed you briefly earlier. Just want to point out, this is the ipsilesional gain here, 0.17. It's very weak. The blue arrow is showing compensatory saccades. The red eye velocity should match the black head velocity. This is search coil recordings. We do this training. This is a person with a unilateral vestibular hypofunction. The VOR gain towards the healthy side is healthy. It's normal, 0.82. We bring them into the lab, and they turn their head to their ipsi and contra side, the bad and the good ear, and we drive the gain up on both sides. We've created a problem. Look at the VOR gain on the normal side. We went from 0.82 to 1.4 just about. You can see that the red eye velocity is moving faster than the black head velocity. We've created a problem for their good side. On the other side, this was really exciting. We restored their gain. It went from 0.17 to 0.88 after 15 minutes. And it's now comparable to their contralesional side. But we did create a little bit of a problem here. The other thing to notice is that the compensatory saccades are no longer needed. The VOR is working. We don't need a saccade to augment gaze position. And so this was exciting, but led us to think, well, maybe we should adapt the VOR to one side. And so another busy slide, but just to show that we started to apply it to one side only. The way that we did this, however, was they would turn their head towards the affected side. The laser target would move in the opposite direction, just like the method that I showed you with that cartoon earlier. But then we had them turn towards their healthy side in the dark, no laser target. And when we did that, there was a bleed over of the motor learning. The gain from the affected side was increased, but it also increased a little bit. Not the same as when we had a target, but it did increase a little bit. So what we learned we had to do was just keep the target on, but not moving. So in summary, for folks that have a one-sided loss of vestibular function, if they're going to use this particular method, they can either turn their heads only towards one side and the target will move. If they're going to turn their head to the other side, we need to provide a target that's on but doesn't move, because if they are turning their head and there's no target on, there's going to be some bleed over from the learning. And that's what this is showing, just that when we do that method, we can drive up the gain on the side we want, which is the red arrow. On the side that we don't want, we can keep the gain at its normal amount and not drive it up. The next paper we looked at was, well, what about these patients with unilateral hypofunction? So this is just showing that this is a pre-adaptation gain of 0.79. It's borderline. Remember, 0.8 is abnormal. This is search coil. Search coil VOR gains are more, the variability is less. And so what's normal in search coil is not the same thing that's what's normal in video head impulse testing. But nonetheless, the VOR gain in this patient goes from 0.79 before training to 1.1 after training. So again, we've restored the gain. In this early proof of principle kind of paper, these were patients. We had 4 patients where we did this, wore search coils, did the training. 2 out of the 4 patients had some difficulty doing the task. The VOR gain changed. It wasn't statistically significant. If you look up here at 2 of the 4, so 50% had significant changes in gain. Now, when we say significant changes, I mean statistically significant. Clinically relevant, we still haven't figured out, right? If I say to you, we can change your gain from 0.3 to 0.5, that's a big percentage change, but clinically, does it make any difference? Does the patient perceive it? And that's what we're starting to do now. So this is exciting. If I had a vestibular deficit and you told me you could change my gain by 43%, I would jump all over that opportunity, but we still need to prove it's clinically relevant to the patient. So, but half of the patients had a hard time doing the task. There's a little bit of learning and training that we've learned we have to do. So I wanted to pivot a little bit. This next slide is illustrating a patient that has a unilateral vestibular hypofunction per caloric exam, but on head impulse testing, the contralesional ear still is also reduced. So here's the VOR gain on the contra or the healthy side, 0.64. You can see the green eye velocity does not match the blue head velocity. It gives us that lower gain, and we see these sharp peaks. These are the saccades that are augmenting the VOR. And on the right side, the caloric identified weakness, we see the VOR gain is much worse, 0.3, but that there is this abnormality on both sides. And ideally, if we're going to treat our patients, we would like to be able to augment both. We want to drive up the healthy side a little less than we want to drive up the affected side. And that's the point of that slide. So we did a study to see, well, can we drive the gain up simultaneously in 15 minutes by giving them an error signal such as this? And that's what's illustrated here. It's a little bit confusing, but imagine this. You turn your head to the left, the target moves with your head. That's going to lower the gain for leftward head rotation. When you turn your head to the right, the target moves to the left, same target direction, but that's going to drive the gain up. So that's what we did. We brought people in, we drove their gain up on one side and down on the other side for one experiment. We brought them in a second time, we drove their gains up both sides. And then we brought them in a third time and we drove their gain down both sides. So that's essentially what the design was. And we'll just focus on this particular slide data here, which is a single subject representative. So what you're seeing here, pre are VOR gains before, and they're normal, 1.02 with a little standard deviation. Red is the eye velocity, black is the head velocity, they match. After we adapted the gains up using this laser method to both sides, we drive the gain up to both sides, 1.32, 1.22. That amount of gain change is 30% for the left and about 20% on the right. Brought them in another time, drove both gains down. We go from 1.02 to 0.86 and 1.04 to 0.9. They're the percentage gains there. And then a separate time, we randomized the order, and I don't know what the order was for this particular person, but this is the exciting part. So when this person turned their head to the left, the VOR gain goes up to 1.26 by 24%. Concurrently, when they turned their head to the right, it went down by 22% to 0.82. So that established the principle that the brain can tolerate simultaneous error signals for head rotations to the right or to the left, so that we should be able to give a patient with a mixed VOR gain, that is, they have a bilateral VOR deficit, but it's asymmetrical. And a lot of folks we see do have bilateral and asymmetrical gains that we could drive asymmetrically. These were the group results. We won't spend that much time on this. It's just to prove that this happened as a group as well. So that was an individual raw data trace. This is just to show that when we drive the VOR gain up as a group, everybody goes up. When we drive the gain down as a group, everybody goes down, whether it's active or passive head rotations. And then when it's mixed, which is this square, you get this mix up or mix down appropriate. And that's the implication here for rehab, is either that head rotation to one side may be enough, or we have to give them an error signal to treat both sides. One of the questions that the rehab providers have asked us is, well, the training is always done actively, right? When you guys, when the physicians send the patient to vestibular rehab, the rehab provider gives them exercises to take home that involve active head movement. So rehab providers have asked, well, if they're turning their head actively, but you're measuring their vestibular reflex passively, is that incongruent? Is there a confound there? And it was a good question. And so we studied that and found out that no, it doesn't matter, which was good for us. So what that means is we had subjects come in. Now, these were healthy controls, might be different in patient population, but to date, in healthy controls, you come into our lab, and these were brave subjects. We turned their head. We did basically passive VOR training. So they wore the laser target. We turned their head to the right. Laser target moved a little bit to the left. We did that for 15 minutes. We measured what was the magnitude of the gain change. Then we had them wait about 10 days, bring them back into the lab, and do the same thing with active head turns. And what we found was that the VOR gain change, when we measured active head impulses after active training, the VOR gain change was significant. When we measured their passive impulse after active training, it still was the same magnitude. It didn't matter. And the opposite was true. So we brought them in passive training, measured active, good change. Passive training, measured passive, same. So this convinced us that we probably do not need our patient subjects to do passive or be exposed somehow to passive training. Now, to bring you up to date on what we've been doing recently, and then we're going to pivot to one final clinical. I think we've got four slides or more, and then we'll finish up. Is that we've done clinical trials now on this method. We've done 2 clinical trials, and that's what a couple points to illustrate here. What's on the left side of your screen are the incremental VOR adaptation method. This is the laser method that I showed with the laser target. The control was the laser target did not move. And so what we found is that only this method can significantly increase VOR gain by these percentages, whether it's a passive impulse gain measure or an active impulse gain measure. So 30% increase in the VOR to passive impulses, or 21% to active impulses. But there's a training effect. It is retained, but it reduced by about 60%. So that's not that surprising, right? When we train for a race, we do our aerobic training. We train for the 5K, the 10K, for those that are really crazy, the marathons. And if we don't continue to run, we lose that aerobic effect. It's the same thing here. The control group had no significant change in gain. What I wanted to illustrate was 2 things here. So this is the intervention. This is a subject. This is a crossover design. So here's a subject who is doing the training. The VOR gain is 0.23. They come back at month 3, it's gone up a little bit to 0.29. They come back at month 6, it's up to 0.35. So they've had significant gain increase. Then they go into washout. They go into washout, and their VOR gain at this plot here at this washout row is the same as this plot here. So 0.35 at the beginning of washout. They don't do any rehab, but at month 3, they come back during the washout, the gain has gone up again. And at month 6, it's stayed. It stayed. So that was interesting. We did not expect that once we started this training, it's as if we trained the brain how to augment on its own a little bit, and it bumps the gain up. We saw this in a couple of other folks, and that is interesting. We did not expect that. The Michael Lacour in France has shown that there is some influence on adapting the VOR early on. Now, this is not using this incremental method technique, but I threw this slide in here at this point just to illustrate that we have to date only measured the incremental VOR method in patients with chronic vestibular hypofunction because we didn't want the influence of natural recovery. But this study by Lacour has shown that if you take people early and you introduce them to vestibular physical therapy early using a gaze stability training paradigm that involves coming into the lab, turning the head, and trying to identify a letter, dynamic visual acuity. So the letter only flashes when they make a certain head velocity. If you do that early on versus waiting, if you wait, then these people have a gain augmentation that happens better than those who were delayed for that introduction to that training. So this is acute. There might be some natural recovery that's part of this response, but nonetheless, this was a controlled delay into the rehabilitation paradigm. So there's something to be said, perhaps, for this early intervention that the incremental method may also take advantage of that we have not yet done. The last thing I wanted to just illustrate was this idea of vergence. So up to this point, we've talked about this device. It has promise. The technology has been licensed. Eventually, hopefully, it'll be useful for the population that have vestibular hypofunction. For those people that don't have access to the equipment, of which is everybody right now, has not been developed, there is a phenomenon that you may be familiar with called the vergence VOR gain enhancement. And I'll just briefly go through this and to summarize all this to say that if you look at a very near target, 15 centimeters from the bridge of the nose. So looking at a very near target, and turn the head, the gain has to go up right away by about 25%. Normal physiology. And that is because when you rotate the head and look at a very close target, the eyes translate as well as rotate. And so the brain has to augment. And this has been known. That's what's shown here. This is the VOR gain raw traces from scleral search coil. Head and eye velocity are 1 for a far target up here. That same person, when is looking at a 15 centimeter placed target, the gain goes up. You can see the gray stippled eye velocity is faster than the head velocity, instantaneously. And we know that this phenomenon is dependent on a certain amount of function in the inner ear. So this vergence effect was measured in folks that received gentamicin injection, and it ablated the response. So we see the the far target gains are, it's hard to see there, but it's 0.55. And after, well, looking at a near target, it doesn't change, it's 0.56. So gentamicin and the effect that has ablates this response. However, if the surgically plugged, as in canal dehiscence, the vergence effect is retained. So this is in the plane of the superior semicircular canal, head impulses. And we see the VOR gain goes from 0.67 to 0.83. It's hard to see those numbers, they're small, but I think you can appreciate that the gray eye velocity is matching better the black head velocity. So it kind of depends on the lesion. So what we were interested to do was, nobody's looked at this in neuritis and the more common causes for vestibular hypofunction. So we brought patients in and did video head impulsing testing at near and far targets towards the side of the lesion, and of course away from the side of the lesion. And what we found is that yes, on the healthy side, the VOR gain can be augmented. That's what you'd expect. So head rotations towards the contralesional side, VOR gain goes up when they look at a near target. But there was no difference when they were head rotated towards the affected side. The gain did not change. This is the list of all the patients here, just only to show that we had the majority were vestibular neuritis. We had a couple schwannoma, we had a couple with central pathology. So in summary, the VOR gain enhancement is preserved for contrarotational gains, not for IPSY rotational gains. Now, it turns out that 8 of these subjects showed natural recovery. It does happen. We've all seen these patients in our clinic where the system does recover. Recovery was based on passive VOR gain to head impulses were normal now. And in those folks, the VOR gain augmentation went up by 10% on the affected side. That was not clinically, statistically significant, but I don't know if it was clinically. So what I mean is, I don't know if it was relevant clinically, but it did change by 10%. That was not clinically relevant. So some of our patients will have natural recovery where maybe this vergence phenomenon would be restored. So summary plot showing basically the yellow arrows don't show any change, which is the IPSY lesional side between far and near. On the contralesional side, the near blue arrow is higher than the far side. So that's kind of redundant. The last couple of slides here to show you an exercise that we created to see if it would change the VOR gain. So what you're seeing is the vergence VOR times 1 exercise. So the subject is moving the target towards the bridge of their nose while they're turning their head left to right. And what's plotted here on the left is the VOR gain during that particular movement. So let's take a look at that. That's down here. So in this bottom half, the gray area is the target coming to when it's at the nose. So target right at the bridge of the nose. We can see the VOR gain there is 1.5. The stifled eye velocity is higher than the gray head velocity. And as the target moves away, the VOR gain drops down. So this is a healthy control, but nonetheless, the VOR gain is instantaneously going from 1.0 at arm's length up to 1.5, bridge of the nose, and then back down to 1.03. So we thought, well, what if we did that as an exercise? So I'm going to show you pilot data where people did this particular exercise. They held it 15 centimeters from their nose and just did 15 minutes. It was 1 minute with 30-second breaks. So that's a long time to do this. Fair enough. But they did this as a home exercise program. Here's what the raw data showed in one patient. We've got a 13% change in VOR gain, probably not relevant. Goes from 0.3 to 0.34. Just draw your attention to the blue plot here, the blue eye and head velocity. Here's the head. Here's the eye velocity. It's not inverted. This is a different method of the video head impulse test. But you see, this is a saccade. So the VOR is deficient. We've got a saccade here. After the training, the saccade is largely gone. So we're having some effect. Don't know what it means yet. And this VOR gain is probably not significant. But here's another patient. Same left-sided abnormality. We see the VOR gain go from 0.65 to 0.77. That's now almost normal. Remember, 0.8 is normal. It's 18%. That probably is clinically relevant. We see the same phenomenon, though. Look at this. We have the saccades occurring early, and then they disappear. So we're having an effect. This VOR gain change is probably significant for this particular subject. So we think that this particular home exercise is probably going to be superior than what's currently out there. We now need to prove it, and that's what we are currently doing. And I'll just put this last summary slide here that we've done this in 11 subjects. We are continuing this study, and half of them have had an immediate improvement in the VOR gain after this particular exercise. But the other half roughly have not shown an improvement. And so, we have to figure that out. We think that there's better ways to train the VOR that are currently out there, and there's more to come. So I thank you for listening.
Hello, my name is Dr. Kevin Peng, neurologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.